This is a disaster review. I know that everyone in this room has done some ADLS stuff, so we're going to fly through it kind of quick like. So I don't have any conflicts of interest. I'm not pro-disaster or receiving money from big disaster. Please give me feedback on what we're doing here. So what are your objectives? So to summarize, you want to control the scene. You want to sort out your patients, do life-saving treatments, which is a little bit different than what we do every day in the emergency department, evacuate and recover. So if you're interested in more ADLS training stuff, you know how to contact us because we're the folks that trained you. So what is the definition of a disaster? They go over this a lot, but it's really kind of simple. When what you need acutely exceeds what your resources are, it's a disaster. If you're a small emergency department, a one-car crash could be a disaster because it's more than what you have the ability to take care of depending on what's going on. You've got both natural as well as human-made disasters, right? So natural disaster is pretty, obvious. When God smites you and rains down fury from the heavens, that's going to be a natural one. Human-made ones are a little bit interesting because you're probably thinking of things like mass shootings and whatnot, but there's also unintentional disasters such as building collapses and things like that. They can actually be an unintentional human-made disaster. But sadly, increasingly, there's a lot of intentional disasters where bombs go off, people get shot, etc. So there's that altogether too handy acronym of disaster. It's too long to remember, but we're going to go through each stage of this to help you remember some of the key points. So first off, detect. If you don't know that a disaster is happening, you can't really meaningfully respond to it. So what does that look like? So you're going to become aware of it, right? So what things are alerting you that something bad has happened? And every time I've been a part of smaller disasters I've taken care of in the emergency department, it wasn't really clear exactly what happened. Something bad happened. You've got some patients coming in, they seem sick. But it's only in hindsight that you really understand what's going on. And then get help, right? So you want to alert authorities, let them know that we're going to need more than what this one shop can do, and assess the needs of the situation, because is this going to need a big cleanup? Is this going to need a bunch of trauma surgeons? What is it that we need here? So then you got incident management, right? Which is basically going to help you link beyond the local response. So it's not just what you're doing there on scene, but also what you're doing beyond. You also have to establish roles. Who is doing what? And having that lines of communication. Every time I've seen a disaster take place, communication is one of the first casualties. And being able to communicate with the folks that are on scene versus the folks that are in your big centers is really key, because it's very hard to actually know what's going on. Don't rely necessarily on cell phone towers being able to work or the internet working, because very often with these disasters, those things either get swamped or get taken down. So this is one of my big highlights. So if you fell asleep for that first stuff because it's a little dry, pay attention here. Safety and security is something that we don't talk about very often in the emergency department, because almost by definition, by the time they come to you, the scene is secure because you're in a level 1 trauma center, right? This is not always the case at these scenes. And this gets drilled into paramedics. So the people with pre-hospital backgrounds are like, yeah, duh, of course, I'm going to make sure things are safe. I can't tell you how hard it is for a physician that doesn't have a pre-hospital background to see someone hurt and not just run in there and get hurt themselves. So is the scene secure? Are the ins and outs of a scene secure, right? So if there was a dirty bomb that goes off, do we know where people are able to come in and come out of whatever area it is? And if it's not secure, you need to make sure that it is secured so you know exactly where people are coming in and out, and then anticipate environmental changes. So a classic one of these is if you have a car crash and it's near a river and it's raining heavily and flooding is increasing, is that water level that's currently not a problem going to become a problem, okay? Are those storms that are continuing to happen after building collapses in a hurricane, are those storms going to continue to cause further trouble? So anticipate those environmental changes. If you have a bomb go off and there's gas everywhere, what happens if the wind blows a different direction? You got to be ready for that. So you help no one by becoming a casualty. So rushing in there, trying to do the medical stuff that you so desperately want to do, you're actually becoming part of the problem because you're yet another injured person. So what is your priorities? So first is going to be you as well as the other providers that are there, right? You don't help anyone by becoming another casualty. Then is actually the uninjured person, which is really hard for us because we want to rush in there and take care of the sick people, right? But if they're not actively hurt, you want to make sure that those people are protected. And it's relatively easy to protect those people compared to saving a life that's, someone's already been shot or something. Then you have the injured people, which is obvious and what our mind naturally goes towards. And then the environment. So increasingly they're looking at what happens to the area that had this terrible disaster happen. Are we stopping the leakage of further gas or whatever so the soil's not contaminated and whatnot? I'm not enough of a hippie to really care about that last one, but it's part of the curriculum. So next up is assess hazards. Okay, so it's fairly obvious in some situations, like a gunman, that if they're still firing bullets, it's a bad idea to run out there. Okay, but I want you to think of all the other ways that can happen. Bomb makers are getting more sophisticated. Well, they'll set off a relatively small bomb, and then they know that all the medics are going to rush in there, and they set off a bigger bomb to take them out. Are there other people that are laying in wait, such as snipers? Is there signs of structural collapse? So remember the World Trade Center, the buildings didn't come down right away. It took some time, right? What about utilities? Do we have down lines, things like that? Are there fires that are currently happening or about to happen because that car is smoking and might actually go off? Are there later explosions that can happen from unanticipated things? And what about the crowd surge? Because this is actually one of the things that kills more people than any of the other ones, is people panic and that herd mentality takes off and then a bunch of people get trampled. So if you shoot 3 people in a crowd of 10,000, it's quite probable that those 10,000 people that didn't get shot running away are actually going to kill more people than 3 that get shot. So next up is triage and treat. This is very close to home. This is what we talk about all the time. We're going to cover salt triage very briefly. Control bleeding. If you did nothing else other than throwing a bunch of tourniquets and putting pressure on people that are bleeding, you'd be doing God's work here. TXA is great, but this is not actually the time for it. You'll have to come a little bit later. Opening airway is essential. So sometimes a simple jaw thrust is about the only airway move that you're going to do most of the time, because unless you've got a backpack full of 100 LMAs, this isn't going to go very well. Needling the chest is a critical procedure that we'll talk about a little bit more. But I want everyone to actually pop out their smartphone and actually go buy a tourniquet from Amazon. There are cat tourniquets that are out there that are pretty cheap, and we'll talk about that more in a minute. But seriously, like, stop listening to me and buy a tourniquet on Amazon. They're about $15, and you'll feel better knowing it's in the trunk of your car. Next up is evacuate. So you got to get people from wherever the badness was to somewhere else. So having collection points makes a lot of sense. There's definitely an art and a science to this. But to be honest, your idea of ground EMS has to transport all these folks is probably going to get overwhelmed in all but the most minor of disasters. There's actually a signal that people that got transported by other methods, such as police or something like that, actually had better outcomes. Now, that's not because cops are better at providing medical care than paramedics. Absolutely not. It's because the cops scooped and ran. And that's actually probably a very appropriate thing to do for many, but not all disasters. Okay? It's very complicated. But knowing that a lot of folks from a disaster are actually going to self-transport in ways that are going to make you uncomfortable. You know, a redneck with a pickup truck that took 10 people from a concert and threw them all in the back and driving to the nearest level 1 trauma center is not good, proper pre-hospital care, but it's better than waiting for 3 hours until the next ground crew can actually pick them up. And so that happens a lot, and you got to be prepared both on the collection side of this is where they're sending us to, as well as knowing that's going to happen there. You might have to break some rules to make it happen. And then recovery, which again is kind of boring, so I'm not really going to talk about it. It's both the physical recovery of the victims, the mental health stuff with PTSD, which is a huge component of this. When disasters happen, people are shaken for a long time, as well as environmental stuff. Just because I don't really have enough time to talk about these things properly doesn't mean that they're not really, really important. But it's one of those things that we don't properly discuss. Is what happens when a town is literally missing after a hurricane wipes it off the face of the earth. So let's go into a little bit more detail. You got salt triage, right? I want you to forget all the other garbage triage systems out there. This is the one you should use. This is the big picture idea. Let's break it down. So first off, you got the global sorting. You got your walk, you got your wave, and you got your I can't walk, I can't wave. So the first line you're going to do is that if you can hear me and need help, move to X, right? This is the sucker move, right? This is, I'm going to get you to go over here because the fact that you're able to move over there means that you're not going to die in the next 30 seconds, most likely. So you're getting all those folks to move away. Then if you need help, move your arm or leg, right? So the people that are still there in that pile, okay, can they move their arm or leg? So we're going to do it in this room. So using your last name, okay? Last name, the first letter of your last name, you're assigned to each of these groups. What does this look like? Okay, everyone got it? Everyone know their ABCs? Got it? Okay. So if you can hear me, need help, move to the wall. Actually move over here to this wall. Yeah, come on. I know it's Wednesday. Come on. Come on. Yeah. Okay. Next up, if you need help, move your arm or leg. Right. Okay. So notice that some people didn't do either. Now, those are the folks I'm going to come after, right? So the U through Z are still inobvious, which means Eric's dead. probably. But he's the one I'm going to go for first. Yeah, Dr. Wild in the back as well. But that's what it looks like. So you got the ugly, the bad, and the good, right? Not quite the Clint Eastwood film. So once you do your very first initial assessment, you got the ugly, right? This is the breathing, right? Are they not breathing? Well, they're dead, okay? This is not good. But you're going to basically move on from them in almost all disasters. Next up, you got the bad. So they are breathing, but they've got something like this going on, right? So they can't follow commands. If they don't have a peripheral pulse, they're not, if they're not in respiratory distress or they have major hemorrhage, any of that stuff is going on, you got to do something about it, right? If they're bad enough, you might say they're expectant, meaning that you don't think that they're going to make it at all. Otherwise, you're going to do an immediate thing to fix them. What does that look like? We'll talk about it in a second. Then you got your good. Now, some of these folks are badly injured. You can have bilateral femur fractures and actually still be delayed. So I want you to reset your mind from what you think of as bad situations to what's going to happen in a disaster scenario. If you're not dying or immediately about to die, you're no better than a delayed. So cat tourniquets. These are my favorite tourniquets. I've played around with some other ones and don't like them one bit. Just a quick recap, you're going to loop it around. You're going to tighten it up. That little thing called a windlass is what's going to tighten it up and then secure it. Okay. All you got to do is make sure it's tight enough to where you can't feel a pulse on the other side. As soon as you exceed that, it's good. If you can still feel a pulse, you can actually hurt people with cat tourniquets because you might actually encourage exsanguination if it's not on tight enough by preventing venous flow, but still allowing arterial flow to happen. So make sure that you check that pulse. It's easy to forget that in a situation like this. And then you're going to want to time what time it is. If you forget to do this, it's okay. So remember, go online. I don't see enough people ordering it off their smartphones. Go buy a tourniquet. How much does it cost? If you buy the name brand guy, when I last checked, it was $32. That's great if you're rich. If you're living on resident money, for $17, you had a pretty good knockoff. I don't really like copyright infringement, but I'd rather you have one of these than say $32 is too steep for me. The really cheap ones that are like $5, don't buy those. They're crap. So you really don't want a tourniquet you can't count on. But while preparing this lecture, I bought 2 more. I said more because if you don't have one of these in your car, you don't know the peace and serenity that you have going down the road knowing that you have a tourniquet in your trunk. What about airway stuff? Well, I want you to open the airway. Okay, this isn't time for intubations. Leave your laryngoscope at home. Okay, so just a simple head tilt jaw thrust. Worry a lot less about a C-spine precaution. Okay, because if there was a major event and you move their head a little bit to make them be able to breathe, your only other option is to walk away and let them die. Okay, so worry a lot less about C-spine. Needle decompression, absolutely critical. We've been teaching it wrong for years. So this is a photo of me, so historically we taught people to put it at the A site, right, the second intercostal space, right? Well, there's a bunch of reasons, both because of the number of cheeseburgers that Americans eat, as well as the difficulty of actually figuring out where the second intercostal space is. That's probably a really bad idea. And increasingly, it looks like you should actually be doing it just like you do a chest tube, which is right there. And if you actually look on the photo of me here, you see that if you get right behind the pec there, that's going to be the closest way to get in. And the other 2 sites, it's pretty obvious in this photo that is definitely me, that you would actually have a much harder time getting in there. Be that fat, muscle, whatever, it's almost certainly better to go the anterior axillary line just where you put a chest tube. Okay? So ignore the other places. ATLS is still working on getting that improved. So we're going to run through some scenarios. So you got 25 people shot at a parade with an assault rifle. Okay, a bunch of people get shot at a parade. First, scene safety, right? So before we even get the questions, like, is this taken care of? Because the resuscitation fluid of choice here is actually gunpowder. Someone needs to take out the guy that's shooting other people so that we don't have further injured people, because you can't get out there and take care of people until that scene is safe, right? So first we do the sorting, right? The walk, wave, and still. Then we're going to look for breathing or other major signs of injury. Then we're going to zoom out. Okay, so let's do it. We got 3 patients, all right? First one, you got a 22-year-old with a gunshot wound to the head, with no respirations. What category are they? Dead. Dead. Here, raise your hand to answer. I'll explain what these are in a second. These are industrial Sharpies, okay? And I'm going to explain some uses of them in a second. One is that they're sterile because they have a high alcohol content, so you can actually use them on multiple patients. I honestly don't care if they're sterile or not. If you get shot and you complain, that's a dirty marker. You're too healthy to actually merit my care. Second, they're permanent. Other things wash away, including, yes, regular Sharpies. These are up to 500 degrees Fahrenheit, so unless you autoclave your patient, it's staying there. So be careful what you write on them, and that's why I don't really like the write on the forehead thing, because if you put that someone's expectant to die and they have to stay in the ICU for 5 days, it's awkward. You're like, yeah, what's that on my head that says expectant? We're expecting you to live, sir. It's everything's good. So I recommend that you pick a forearm or a thigh, depending on what body parts are missing. But yeah, the big X on the forehead, not a great look, okay? So, raising hands. You got an 8-year-old gunshot wound to arm, brisk bleeding. What are they? Immediate. I'm not a good aim.
Depends on if you throw a tourniquet on them.
Ooh, nicely done. It could change, but right then, before you do anything, these are all before you do anything, they're an immediate. After you do that, they might almost go down to minimal. I mean, like it really could get pretty low, okay? So, cat tourniquet, right? Patient C, 48-year-old gunshot wound to thigh, mild bleeding, but can't walk. I need a hand. Delayed. So you're going to apply pressure and recheck later. This is just mild bleeding, okay? Scenario 2, right? You got explosion at a chemical plant. 10 people were injured in blast. We have no idea what it is because, honestly, factories are too confusing, and we don't know what magic stuff they've got, okay? So first off, scene safety. Before your paramedics rush in there and breathe in whatever gas and join the people that are dying, you have to figure out what you need. So protective gear, for example. Do the patients that are coming out of that mess need decontamination as well as scene control, right? These are all critical things that we don't have long enough to talk about, right? So remember, global sorting, look for the life threats, and then zoom out more, okay? So we got 3 patients. You got a 33-year-old, gurgling respirations, not following commands with a weak pulse. Immediate. Expectant. Yeah. So gurgling respirations, right? So do you think a chin lift's going to fix this guy? Yeah. Well, I'm going to give the marker to Chuck. By definition, these are tough, right? But this guy's probably not going to make it because it's not just an airway obstruction. He was involved in a chemical injury. It's unlikely that you're going to fix it with just something like that. Okay? You could still absolutely do the chin lift, but if you didn't have immediate response to that, it's going to be expected. Okay? You still want to go back and recycle through these because people should not be triaged once. It should be an ongoing process. Okay? Next up, 53-year-old with kidney injury to right chest with respiratory distress. Immediate. Oh, Baines wants a marker, but not quite quick enough, right? So this would be one that you could do something immediately for, right? All right, remember, ignore that second intercostal nonsense. It doesn't work. Next up, 22-year-old with asthma. Moderate wheezing, though. Following commands. What do you want to do? Yeah, it's delayed. Oh, look at the assist. That's nice. So, decontaminate, recheck later for worsening, right? Because they could get worse, okay? They could get worse. Scenario 3, there's a hurricane hits, there's flooding, there's wind damage, the power's out every which way. First off, right, scene safety. So even though this is a bigger disaster, it's a little bit harder to wrap your head around how do you get safe in a hurricane, making sure that things are all right. So get supplies, evacuate people prior to the storm even getting there is absolutely key, and activate emergency plans, right? So remember, sort, the walk, the wave, the still, life-saving fixes, and then zoom out, okay? So we got 3 more patients. Got a 3-year-old with a 6-centimeter lacked arm, no active bleeding. Minimal. Man, you don't like that kid, do you? No. If there's no active bleeding, it's okay. Control it and let them move on.
So
remember?
Minimal is like you don't even have.
Yeah. So remember, if you really look at the triage, you can actually be kind of sick, right, and still be minimal. It's surprising. So if the bleeding is mild and can be controlled like that, you can actually have broken bones and such, and it still be minimal. You have to reset what you're thinking. This isn't a level 5 chart that comes in the ED. Almost everyone that's even delayed are going to be 2s and 3s, right? So these can actually be fairly sick folks. 53-year-old diabetic who lost the med, their glucometer says high, and they smell like ketones. This is a fruity scent. What are they? Yeah, good. So again, this person is probably getting admitted to the ICU eventually, right? So this person is critically sick, yet they're only a delayed because they are sick in a more of a smoldering fire than a sudden cannonball disaster, okay? So even though this person is going to need resuscitation, probably be admitted to the ICU for a couple of days, it's still the case that they are only a delayed. And last but not least, you got a 13-year-old cut by debris, brisk bleeding through a gauze bandage. Immediate, right? So again, that cat tourniquet. So remember, if you haven't already done so, why have you not bought a tourniquet? I cannot emphasize enough, you should have one, probably 2 of these in the trunk of your car, or else you're a terrible human being. So remember, refresh yourself on some of the stuff that we've already had for ADLS. Do we have any questions at all? Thanks, guys. I forgot that I did the thing of the questions after the key points. So to refresh, scene safety, don't be a casualty. Walk and wave to figure out who's got what. Use tourniquets because tourniquets are cool. And prepare in advance. Thank you.